Hi, my name is Jennifer Lowe, and I'm an ophthalmologist in Miami, Florida, with a focus on cataract and refractive surgery. I'm here today to speak about what happens and how to manage when you have a refractive surprise after cataract surgery. So, these are my financial disclosures. So, we all know that a perfect surgery does not always equal a perfect result, unfortunately. Patients are often disheartened and disappointed when they don't think it's a perfect result, right? And it's especially difficult in the refractive cataract surgery patients that have possibly paid a lot of money and put a lot of expectations into their surgery. We know that preoperative assessment is crucial, but postoperative management is also essential in when you're managing with these patients. So, how do you evaluate patients that are off target in terms of their refractive error and unhappy after the cataract surgery? Well, it's really important to have a comprehensive workup postoperatively. All the tests, same tests that you did preoperatively to assess your patients, you really need to repeat them after, including topography. You have to make sure that nothing changed with the topography. Maybe LRIs were performed and the axis changed, or maybe even the main incision caused the axis of astigmatism to change. Ensure that there's no retinal issues. So I would encourage performing an OCT of the macula. Things like CME or other issues like a VMT or ERM could cause problems. And then also the most important one, really, the most common problem is really the ocular surface, right? So dry eye and MGD are extremely common postoperatively. We know that actual physiologic changes in the eyelid, lid margin, meibomian glands, ocular surface exist for even at least up to 3 months after surgery per some studies. And so things such as the iodine solution that we use to clean the eye and the topical postoperative drops can really hurt the ocular surface and make patients not see well after surgery. So very critical to identify this. So who is really at risk for problems with cataract and refractive surgery? Well, patients that have had prior refractive surgery, such as LASIK, PRK, and especially RK, that can make their refractive outcome very difficult to predict. Watch out for patients with corneal disease. Look for that subtle epithelial basement membrane dystrophy. Also look for things like irregular astigmatism or Salzmann's nodules, scars, dry eye, like we just talked about. Those patients that have a long or short axial length also, right? Those are the outliers that can have problems when we run our normal nomograms and formulas, as we've seen. And then if there's some disagreement in the axis of astigmatism, that can also indicate a problem. There could be, dry eye disease or other things going on. So you really have to make sure that all your diagnostic devices are quite consistent. So there was a study performed by Dr. Kendall Donaldson and Dr. Gibson that showed the two main reasons for unhappiness after a presbyopic IOL are refractive error at 57% and dry eye disease at 35%. So always keep those two things in mind. Again, the two most common reasons for someone to be unhappy after a presbyopic correcting IOL are refractive error and dry eye disease. So really important to keep that in mind. Now, what if you do if all of the tests we just discussed are normal, but there is still a refractive error? And that's what we really want to talk about today. Well, again, I would encourage you to repeat all tests, including a refraction, maximize the ocular surface health. You have to decide whether you want to perform a YAG capsulotomy or not. And I urge you nowadays to be more cautious in that. If you think that the problem is refractive error, we really don't necessarily want to jump to the YAG capsulotomy if we think we might be going to an IOL exchange, which we'll talk more about. And then you need to figure out how to eliminate the refractive error. I would encourage you, again, have multiple consistent refractions and also strongly consider a contact lens trial in the office to make sure that correcting that refractive error really solves the problem for the patient, especially when we're dealing with things like multifocal or EDOF lenses. And then we're going to go into options for how to correct that refractive error, which include laser vision correction, an IOL exchange, or even a piggyback lens. So let's say you have an unhappy IOL patient with a residual refractive error. Again, like I was just stating, you have to make sure that the refractive error is real and stable and consider, again, the ocular surface disease. And again, like I highlighted here, check with either trial things or even more ideally a contact lens in the office, and even have the patient maybe trial it at home to make sure that this really solves the problem. Don't hesitate to bring patient backs multiple times for topography and refraction. I can't stress this enough. So then you have to decide what refractive endpoint you would like. Does the patient want to be plano, or maybe they were monovision and they're not happy with that and they want less monovision or more monovision? Let's say you have a multifocal patient or an EDOF patient and the refractive goal is plano. That will really help reduce the glare, halo, and spiderweb. That's what we found. So some of these positive dysphotopsia symptoms can be due to refractive error. Another really great option nowadays that we have is the light adjustable lens, and that gives us the opportunity to adjust the refractive error post-operatively, but it's still important to have a plan preoperatively prior to surgery. So what are the treatment options? Well, it's important to remember that some patients would maybe prefer to correct any refractive error with glasses or contacts. So it's still important to give this as an option. We don't always have to push surgery, so it's important to acknowledge it. But of course, many patients were hoping to not wear glasses, especially if they've paid for an enhanced lens. So laser vision correction, of course, remains a popular and viable option. And then we have PRK, LASIK, and SMILE. Piggyback IOLs can certainly be an option in certain candidates. And then IOL exchange. There, you could also consider if there's a small amount of residual astigmatism that's causing the problem. And if the patient's a good candidate, you can think about an AK or a femto AK. Now, really how you decide varies on what their post-op refraction is. Is it a small refraction or is it a large refraction? That's going to determine, what route you want to go. And when was the surgery? Was the surgery performed 5 years ago and they have an open capsulotomy? You may want to avoid intraocular surgery then and lean more towards LVC. And were there complications during the primary surgery, such as vitreous loss? So how do we really decide where to go? Well, you can look at the corneal-based corrections, laser vision correction, and it's nice because you avoid the intraocular complications that you can get with piggyback lenses or intraocular lens exchange. But you do still have risks, right? There's still risks for corneal procedures. You also have to make sure that the patient is a candidate for a refractive procedure, a laser vision correction procedure, and make sure that you feel confident performing such a procedure. Also, there can be disadvantages from a logistical standpoint. What if you don't own your own laser or you don't have access to a laser? You either can find a laser center to take your patients to, or maybe build a good relationship with someone in the community who is willing to help you correct those patients with laser vision correction afterwards. And remember, if someone's had prior LASIK or prior PRK, they may not be the best candidate for repeat corneal correction with laser vision correction. Now, what about intraocular correction? What are the pros and cons to that? Well, some of the advantages are that we're not altering the cornea. We're not inducing further higher order aberrations, and there's no risk for corneal complications such as an ectasia or an ulcer that you might get with the laser-based surgeries. But the disadvantage, again, logistical disadvantages, right? It can be a higher cost. Switching out a lens. Patient has to go back to the operating room and may have a high deductible. It can be more difficult in certain situations like those with an open capsule. And then there's the intraocular risks for surgery, such as endophthalmitis, vitreous loss, trouble getting the implant out. So you really have to determine what your skill set is. And again, going back to that critical question, I think when the surgery was performed can play a big role in what you decide. So I wanted to go through a few cases here just to illustrate different examples of how to troubleshoot these patients. And in my practice, I had a 66-year-old female who presented status post bilateral presbyopic. They were multifocal implants. Her right eye was 3 months post-op and her left eye was 2 months post-op. And she came in with a chief complaint of, quote, everything is now blurry in my left eye. Her right eye was 20/20, but her left eye was down to 20/25 uncorrected, but her near in the left eye was J7. This is her refraction that was performed and only got her to 20/25. So pay attention to that. And as a little clue, when I look back to my notes, 4 weeks prior, she was uncorrected 20/20 J1 plus in that eye and very happy. So what went wrong? Was it a refractive error, decentered IOL, ocular surface issues, PCO, CME? Well, she does report, and I think the history is very important, that there were no fluctuations in vision. The vision problem remained constant at distance and near, and again, no fluctuation. So that helped reassure me that it may not be something like the vitreous or the ocular surface, right? It was very constant. Her OCT of the macula looks good. There was no CME. But on exam, she did have, I diagnosed a 2+ posterior capsular opacification in the left eye, and it did appear worse than the right eye. This was a easy, nice slam dunk case that we all hope for. I simply took her back and performed a capsulotomy on the left eye. And 1 week later, she was 20/20 J2 with this refractive error. You can see low refractive error, plano plus 0.5. So certainly not really able to adjust that any further, but the patient was happy. So that was a nice end of the story for that one. Well, what about a different patient? We have a patient who's 65-year-old female, status post cataract surgery 3 weeks earlier with a presbyopic lens. She ends up being 20/60 for distance, uncorrected, but J1 plus at near. And she literally, I wrote this down. She said, I can see the pores in my skin up close, but I can't see the TV. Of course, we do a refraction, and you can see that she's myopic, which makes sense, right? Minus 1.25 plus 50, that's 171. Excuse me. She corrected easily to 20/20. So I checked the macula. There's no CME, no epiretinal membrane. And when I look back at my notes on post-op day 3, she was actually much better. 20/25 uncorrected, a little worse for the near, but much better for the distance. So 3 weeks post-op, I repeated a topography. It maybe showed like a little bit of dry eye. So of course I decided let's go ahead and treat that with steroid drops, artificial tears. And following my own guidance, I decided to bring her back for a refraction again to make sure it was stable, and also to perform a contact lens trial in the office to make sure it solved her problem. Again, her refraction remained stable as what was before. She actually achieved 20/15, and I sent her the contact to try for a day or two at home and in the office. And she did report clear distance vision, but as I told her, I warned her, if we make this distance vision better, you may notice a little bit of reduction in the near. And she did agree with that. But because she had that opportunity to try out the vision, she did decide she preferred to be a little stronger for distance. So we decided to perform PRK because it was a very stable refraction. She had no prior history of LASIK or PRK, had a good appearing cornea on topography. And I thought that would be a simple case to help fix her problem. Okay, so here's another case number 3. Now we have an unhappy 71-year-old female who had an EDOF toric lens. She comes in on day 5 reporting unclear and fuzzy vision. Her distance uncorrected is 20/60 and her near is only J2. So not great. So what test would you want next? Well, of course, we did a refraction. Only a -1 plus 50, which didn't quite make sense, honestly, with an uncorrected distance vision of 20/60. It was a little off. The topography post-op shows the astigmatism 0.73 at 34. When I look at pre-op, though, you can see that the topography looks much better, more of a normal bow tie pattern. So probably we're dealing with a little bit of dry eye in the post-op topography. You can see there's not like a normal axis there. The OCT looked normal. And so what do we do next? Well, sorry about that. So actually, what was interesting was we looked, did the full exam, looked at her under the slit lamp, and you can see here that she had a decentered implant, right? So around that is the capsulotomy, and you can see that the implant is not centered. And if you look a little more closely with a different angle of the photo, a different type of photo here, you can see that the haptic looks like it's actually anterior to the capsule. So somehow her lens, not only a rotational issue, but was not actually fully in the bag, and the lens was tilted and decentered. So this was inducing unwanted refractive error and poor vision. So what should we do now? Well, she only had surgery less than a week ago, and clearly this needed to be fixed. So the option for that would not be to do refractive surgery, like in terms of laser, corneal-based refractive surgery, but to actually go back to the OR and reposition the lens. I did my calculations. I still was of the mindset that we had picked the correct lens. It was the right lens, so I didn't think we needed to do an exchange, but simply put the lens back into the proper position. So after the IOL repositioning, she was 20/20 J2 with an EDOF lens. So very, very happy. And so that was another nice solution, but it requires going back to the OR, but it has to be fixed. So we don't have a choice. So case number 4, we have a 70-year-old female who presented with residual astigmatism following an uncomplicated toric implantation and cataract surgery. And she's 20/40, the refraction minus 150 plus 175 at axis 130. gets her to 2020, so that's a good thing. At least she can correct to 2020. So, it leads me to believe that there's no other underlying pathology in her eye. But what happened? So why was I so off? Was it a simple rotation? Oh, we'll see. So I'm fortunate to have a technology, a topographer, the OPD3, that allows you to do a retroillumination photo after the patient's been dilated, and it overlays, based upon the topography, the steep axis of astigmatism and the flat axis of astigmatism. And you can see here, the red line indicates the steep axis of astigmatism, and the blue line indicates the flat axis of corneal astigmatism. So, and you may also notice that this implant shows the toric mark, and luckily she dilates well enough to see that, and it is lined up nicely, and I say that sarcastically, with the flat axis, right? So there has been a rotation. So the toric mark should have been lined up with the steep axis or the red axis line, but of course you can see that it has clearly rotated. But and this, also one thing I wanted to point out too, with the laser that I use, the femtosecond laser that I use, there is such a thing called the capsular nub that the laser makes on the anterior capsule. And this helps you align the toric lens in the surgery. And it's also nice because even if you didn't have this diagnostic device, you would clearly see that your toric mark was not lined up with your pre-placed capsular mark. From the laser. But the plot thickens. So again, my knee-jerk reaction was to think, okay, just quickly go back, rotate the lens back to where those capsular nubs were. But I wanted to take my time, just, follow my own advice, repeat all the testing, look back through the chart and check the pre-op measurements. And when I look at her pre-op topography versus her post-op topography, just like I said earlier, it's really important, even if you think something is a slam dunk case, recheck the testing, because you can see her axis of astigmatism has actually changed. Now, I did not perform limbal relaxing incisions on her, simply the normal main incision, 2.4 millimeter, and side port incision. So no LRI was performed, but you can see that the topography axis changed, right? So what happened here? So, somehow it changed, maybe from the SIA, surgically induced astigmatism, from my incision. But, the topography again, and I repeated this multiple times. I had her come back for multiple refractions, multiple topographies to ensure that I was looking at things correctly, treated her dry eye. So we know that she ended up more myopic than expected and also had more astigmatism than expected. So not only was it a toric rotation in the surgery, but somehow her corneal astigmatism did switch. And when I ran the astigmatism fixed calculator, which I always want to check, again, I don't just assume that I'm going back and rotating the lens. I did run the calculations. It actually advised that I should not only rotate the lens, but I actually need to switch out the lens for a different power. So I was able to do that per those guidelines. And thank goodness, after 1 week, she was 20/20. So this is just a pearl. Yes, it's tempting to just rush back and rotate the lens, but do your homework. Have the patient come back several times, make sure that everything looks normal, and even recheck that topography. Even though we assume it's the same, it may not be. So in summary, make sure that you're evaluating all parts of the eye, including the ocular surface, cornea, lens, retina. Look at the patient, determine the poor cause of vision, or the cause of the poor vision. And then repeat the measurements. Even if you think that they have to still be the same as pre-op, always check, and really strongly consider performing a contact lens trial on those patients that have that refractive miss before you go back to the OR, especially so the patients understand what their vision is going to look like afterwards. And then based on that, like we discussed earlier, you have to, use all of your knowledge and determine what's best for the patient, whether you should go back and do a lens-based correction or a corneal-based laser correction, based upon when the patient's surgery was, what their refractive error is, the health of their eye, and other risk factors. And that's it. Thank you.